Great. Welcome back, everyone. We have Jeff Hochberg, president of Vermont Retail Druggists, with us to continue our conversation. Mike Fisher, the healthcare advocate, was here talking about the drug coverage changes with pharmacy benefit, which is those couple drugs that the administration is recommending we stop paying for. These are Medicaid patients who receive these drugs. So we're going to hear from a pharmacy's perspective what your thoughts are.
Great. Well, thank you for the opportunity to speak. My name is Jeff Hochberg, president of Vermont Retail Druggists, vice president of operations for the Spine and Steve Pharmacy Group, 6 independent pharmacy locations in the state. I saw the budget request to remove these 3 products from the covered formulary. To me, it's an example of kind of, I get what you're trying to do. You're trying to save money where you can, but without any forethought as to what the clinical implications are going to be. And I would like to offer up a potential other solution. So the drugs in question, vitamin D, antihistamines, which is a broader category of drugs like cetirizine, generic Zyrtec, loratadine, generic Claritin, and melatonin are all available over the counter. So they are readily accessible, but again, those certainly come at a cost. You're not going to find those for sale traditionally below $1 copay like the beneficiaries of Vermont Medicaid would see. There also is not a lot of therapeutic changes that could be made to some of those products. So without substantial implications. Specifically, let's talk about like melatonin, used to help sleep. What are we going to change to? If you stop covering melatonin, prescribers are going to prescribe things more like Ambien, or maybe benzodiazepine like lorazepam or trazodone, maybe something to help sleep. So you're just going to move it to a different category, a different product in the pharmacopoeia, because one, sleeplessness is not going away. Allergies, which the antihistamines cover, is not going away, and quite honestly, is probably going to upset more parents of children who are, I guess the term would be little snot rockets. And
you can say that
because I got 2 little ones myself.
Exactly.
And they're suffering from the allergies, and we need to certainly help them without making them zombies and comatose when we send them off to school by doping them up with Benadryl. That's not a good alternative. Likewise, the same thing falls suit with the elderly population in the homes. Melatonin is used to treat many seniors to help them with sleep so as not to add on a more heavy narcotic agent like Ambien that's going to have major CNS depression. So these are all and vitamin D, we live in the Northeast. There's a lot of back and forth as to whether or not vitamin D is covered. Are you going to cut vitamin? And then there's questions to be had about vitamin D are you cutting vitamin D alone? Or are you cutting vitamin D that comes in, a multi-dose vitamin or a calcium with vitamin D to help the absorption of the calcium? So again, there's a lot of questions to be had. But these are all very small, low-cost products. They're very cheap. The unit prices of them are significantly cheap. And it doesn't make a lot of sense without creating a clinical pathway. Which kind of brings me up to, it's kind of an expected response, and this is how we treat pharmacy. Pharmacy today is, are pharmacists healthcare providers, or does pharmacy fall under commerce? These are the questions that no one has really identified. I'm of the mind that pharmacists are in fact healthcare providers. They're doctorates in their profession. They have significant expertise with the pharmacopoeia available to us, and we need to utilize them in better strategies. But when we talk about formularies, we don't want to be removing tools from their bag, and certainly not removing tools from the doctors. because you're just going to create a cost shift. It's going to move the needle to other categories of products because conditions don't go away. I would bring attention to products like Suboxone, okay? Not discussed here, but brand name Suboxone film strips used to treat opiate addiction is an example of a product that Medicaid covers, prefers the brand name as opposed to the generic. Now, Medicaid is presumably getting a substantial rebate from the manufacturer. They haven't disclosed that to me or to anyone, I think, in this committee. But the price differential between the brand name and the generic is so huge that I question as to why aren't we talking about things like that? So I did a quick analysis. In my store, I looked at the prices of Suboxone. The brand name Suboxone films, each film costs $8.65 per film. The generic, $1.78 a film. Okay. Now I am a very substantial dispenser, particularly in my Rutland location. And I looked at January's data. I filled 6,530 films in the month of January. The delta between the price of the brand name product and the price of the generic product is $630,000, and that's my store alone. So, again, I point the committee back to saying we need to have a better look at the real financials underpinning drug costs. Is Medicaid getting the full information necessary to make a true comparison as to what the right preferred drug is? But we can also be eliminating drugs from the formulary that are going to leave empty and voids for therapeutic treatment because conditions aren't going away. We need to make sure that all of our providers are armed with as much materials as possible. We should be actually promoting the use of low cost products as opposed to higher cost medications first. The old rule is start low, go slow. And I don't see why we would deviate from that at this point in time. We need to better understand the nexus of healthcare delivery and the markets embedded within the pharmacy industry. Again, the question of where does pharmacy lie on that? Are we commerce or are we healthcare? And I think that's the point that we really want to drive. There's an opportunity, and I know there's a bill I think that your committee might be looking at that contemplates the insertion of oversight in this area, where we can have a true discussion that takes into account both the political aspect as well as the financial aspect and put it together. DVHA has a tough role. I mean, they are they are a payer. Their job is to make sure that they pay for the products for all Vermont, beneficiaries. And that's a tough role, especially if they're not given all the information. This committee, thankfully, helped pass the bill, Act 131 last session, which does make an opportunity for us to have deeper conversations about real costs, real measures, because the ultimate thing is, all our healthcare decision-making is based upon claims data, and, an evaluation of what healthcare is today. I argue it comes down to the prescriptions that come out, every day. You see your pharmacist, 3 to 4 times a month, 35 times a year, as opposed to the 1 to 2 times you might see your primary care physician. And we want to be able to evaluate everybody in that role and at a true performance level. So I think looking at the claims data with real granular detail, really dissecting where the costs are. Is it rebate driven? Is it access issue that we need to solve? Do we have the appropriate therapies in place to cover all different disease states? Those are the decisions to be made, but it takes both clinical and financial working in concert to really make a sound decision. So I would say do not remove anything from the formulary at this point in time.
Thanks, Jeff. We have a couple questions. So I'm going to go Topper, Maury, and then Alyssa.
Thanks for coming in. today, as we sit here, and I just want to use one of the examples you used, Suboxone. If it's prescribed, is the druggist or the pharmacist supposed to put up the generic type as opposed to the brand name?
No, so we are always required to dispense a generic when available. However, if the insurer or the payer for the claim requires brand, we are required to dispense the brand name prescription. Now, this creates an issue with I've seen countless times when a patient comes into the pharmacy, maybe a new enrollee or maybe somebody who's just entering a treatment program, doesn't quite have all their ducks in a row and doesn't have full coverage. So they come in with a prescription seeking treatment. So what are they supposed to get? If they know they're going on Vermont Medicaid as a beneficiary in the immediate future, but not the day they need the med, are they supposed to pay out of pocket for the brand in hopes that Medicaid would go retroactive on a start date and that person would be able to refund the difference? Or do they pay for the generic, in which case Medicaid is not likely to reimburse the patient at all? So either way, it puts them in a quandary. It puts the pharmacy in a quandary as to what best to advise the patient. But in the case like Medicaid, the brand name Suboxone Films is the preferred agent. And that's the one that we're required to dispense.
I didn't realize that.
It's also,
I thought it was the other way.
yeah, I bring up Suboxone as a key point because recent legislative changes nationally are removing the ex-DEA requirement to prescribe Suboxone. It's already one of the top drugs in Medicaid, if not the top, I believe. But now you are going to have this massive expansion of opportunity for providers of all sorts without having any separate classification to prescribe the product. So it's going to be prescribed a lot, both in treatment for opiate addiction and potentially even for pain as well.
Yeah.
So this is all great information and we could spend hours talking about this, which we will at some point. I want to make sure we stay focused on the question at hand, which is the budget recommend to stop paying for these 3 drugs. Mari?
Jeff, thank you for bringing up the point about by removing these from coverage, incentivizing the use of other not recommended medications. And I'm thinking about the elderly now and how, especially for postmenopausal women, vitamin D is critical if they are at risk for osteoporosis, broken bones, hospital admissions related to that. And then, as you mentioned, the slower metabolism of certain medications, especially if they're psychoactive in the elderly, can lead to confusion, unintentional self-injury through taking falls, things like that, from taking Benadryl, as you state, instead of melatonin, or stronger medications like Ativan or Ambien that can have much different and much more dangerous impacts on elderly.
Thanks, Mari. Alyssa?
I was just curious, for the over-the-counter drugs, does Medicaid reimburse you for the full retail price, or is there a negotiated? Okay.
Yeah, it's the per unit MAC price, the drug unit basis of either based on NADAC, state MAC, AWP minus, there's a formula in there, but no, it's based upon an actual ingredient cost plus a dispensing fee for a pharmacist.
Okay, thank you.
Art?
Yes. Can you, so the 3 drugs can be bought over the counter, as we kind of just spoke. So if I went into your store and wanted to buy vitamin D, Claritin, and melatonin, 30-day supply, whatever amount makes sense in your stuff. What roughly would that cost me?
Well, it's a hot dogs to a hot dog bun, issue. So you're not going to get a package of 30. So you're not going to get a month supply. You're going to have to buy a bottle of most likely 100.
Okay, well, that's what I mean. A
And you're
normal
going
amount.
to, you're going to see prices vary from manufacturer to manufacturer, but roughly around, $4 to $5 a bottle.
So each of the bottles is,
Yeah.
so each of the bottles is $4 or $5.
So,
Yeah.
no, I think, I'm not sure we understand the question. So if I want to go into your pharmacy and buy Claritin, how much is that going to cost me?
It depends on what size.
Probably like $8.
$80,
Yeah.
$80.
No, 8
$80.
$8.
$8. Okay. For
Yeah.
how many pills?
Probably 20.
Okay,
Hang on,
so-
let me look it up for you real quick.
That would be good. I think what we're trying to get to is what is the cost to the consumer?
Okay, so you are definitely increasing the out-of-pocket expenses on all the consumers, all the beneficiaries to this, to the magnitude of 400 to 500% without question. They're used to $1 copay as opposed to the retail over-the-counter price, which arguably could also create, inflation. I mean, certainly at a time like the present, all consumable products are have under heavy inflation pressures. Removing a product from a formulary is only likely just to make this more bared out by the beneficiaries themselves. The same thing you saw, or we are seeing currently with like the insulins. There's the IRA, the Inflation Reduction Act, put in the patient out-of-pocket cost cap on insulin to $35. Guess what we saw? We saw immediate drug shortages, and we see immediate price increases on the back end that the average consumer doesn't see because it's all being hidden within the confines of insurance premiums and the like. But
Do you have how much Claritin is?
Claritin, yes,
That's a generic.
Sounds familiar.
generic. Oh, a box of 30 brand name is $20. A box of generic. So generic loratadine 5 milligram is $19.26 for a box of 30. Retail price, the average retail price looks to be around $30. So you're going to see anywhere between $20 and $30 for a box of a month supply of antihistamine, as opposed to $1.
Okay.
Does that help?
Yeah,
Okay.
that's what I want.
Do you want to ask your question, Gus?
I just wanted to clarify, is Benadryl on the list
Okay.
of over-the-counters to be cut?
No.
No?
Okay.
I would assume not, because
Okay.
Benadryl it also comes available in like very large 500 count, 1,000 count capsules that are typically held back in the pharmacies, not dispensed over the counter in the retail packaging. Vitamin D is available in a max strength of 50,000 units for like like a once a month kind of deal. So again, you're just going to move the needle for what's covered to what isn't covered. And the question is that worth it or not? Arguably, no. You're going to be raising costs across the board.
What
Thank
Diva
you.
told me was Diva reassured me that it was, and they can say again today, that it was just the melatonin, vitamin D, and antihistamine.
Yeah.
Right, so we have Diva in the room, so we'll ask them when they come up. Thank you,
The
Jeff.
antihistamines, I imagine it's loratadine and cetirizine. Those are the two over-the-counter antihistamines that are most commonly prescribed.
Great. Jeff, thank you very much. Your testimony was extremely helpful.
It's always my
Thanks,
pleasure.
Jeff.
Thank you very much.
Thank you. Have a great day.
You.
All right, now we are really switching to the commissioner. Let's see. Good, I was about to say good morning, but good afternoon.
Good afternoon.
Feels like morning. So thank you for coming in person. And I think we have a couple things on our list. I think we want to probably talk a couple minutes about this. And then the dental cap
Yes.
presentation.
And the pegging to Delta Dental.
And the pegging to Delta Dental, yes. So there, well,
I'll tell you about that when
Okay.
you're ready.
yeah, we have, and it was a question that we posed in testimony before. So if you don't have the answer, you can get back to us. All right, so let's start with the drug coverage. Did you want to add anything based on what you heard between Mike Fisher and Jeff, or just answer questions?
Well, there's a lot to unpack there, but for the record, Andrea Delabrie, Commissioner for the Department of Vermont Health Access. I appreciate the opportunity to be here today. So I'm not exactly sure where you'd like me to start. Maybe a little guidance there, because I could probably comment on most activities that have, most of the comments, and then activities that we have done as a department to determine that the least harmful approach was to offer the 3 drugs that are over the counter as areas that we could potentially reduce costs. And that was really a directive of the agency to meet a target.
Okay.
Difficult decisions. We have very few levers at Medicaid to make any changes and to slim down the budget, essentially. And that is one of the levers. And unfortunately, we have clinicians, very qualified clinicians. We have a CMO who is an addiction specialist. We have pharmacists who are both from retail and have worked all over New England. We have a clinical operations unit, which has a number of nurses. So we have been very thoughtful about this and are trying to do the least harm possible, understanding that these are not inexpensive pharmaceutical agents. And we know that there will be a cost shift. We know the consequences of that. And however, this is where we are.
Okay.
We prefer not to do this,
Okay.
to be honest.
So you had a number to meet, if I can paraphrase, you had a number to meet and you looked at all the ways you could possibly cut costs, and this was the least harmful way.
In our opinion, it was the least harmful way. When we speak specifically about Suboxone and other opioids,
Which is not part of this, correct? Okay.
it's not a really fair comparison.
Right.
The opioid class is very different than the over-the-counter class. However, if I speak specifically about brand name Suboxone, there are federal protections around disclosing rebates and supplemental rebates. So that's why they're not available. What we do is essentially have a very robust process to develop a preferred drug list for the departments, all publicly available. Suboxone is one of those preferred drugs, and financially, it still benefits the state to use brand name Suboxone. There probably will come a time when it is not any longer financially beneficial. And we have a drug utilization review board that reviews each class on a regular cadence. We had our opioid substance use disorder review in September of 2022. So at that time, it was still in the best interest from a fiscal perspective to keep brand name Suboxone available. So again, we'll review it, and if it doesn't make sense, we make changes based on those.
And eventually this committee will look at pharmaceuticals. So I want to stay focused on this piece of it. So any questions on this 1.7 million cost savings?
That's gross.
That's gross. Yes, I think it's
Thousand,
like,
I think, is state.
it's like 800,000 or something, right? To 800,000 to the state.
Commissioner, thanks for coming in today. And I believe you did an extensive research and so on to figure out which is the least harmful. My question is this: did anybody ask the question, what low-income people who are on Medicaid, did they use over-the-counter solutions to the problems they had? Or was it predominantly prescription?
It's a great question. And so the answer, we did an analysis, a deep analysis on the volume, which is how we came up with the fiscal impact of this. And these are widely used. The over-the-counter medications are widely used. The benefit for Medicaid members is that they don't have to pay more than $1 out of pocket. And we are one of the few payers that covers vitamin D. It doesn't align with other payers, but we currently, until now, have covered it. So I think that there's a mixed bag of over-the-counter options and prescription options, but these drugs in particular are the over-the-counter, available over the counter. Does that make sense? Did I answer your question?
And they're widely used.
They are widely used,
As
yes.
opposed to prescription.
Well, I think prescriptions are also widely used. So it depends on what we're talking about treating.
How about allergies with antihistamines? I mean, that's
Right. I think
the three we're looking at here.
That's a good example because antihistamines, there aren't a lot of options for prescriptions anymore because they have moved that class of drugs more to over the counter than they had in the past. So that's the perfect example.
So the answer to the question, I guess, is if I'm on Medicaid, I'm going to be using over-the-counter stuff more than I'm going to be using prescriptions to solve
allergies. Yes, that's true. At this point in time, that's true. Yep.
But didn't we hear that if someone's on Medicaid and they buy over the counter, that they get do they get a rebate or something?
No, the person does not. So that's a lot was said here about pharmaceuticals that's clouding the picture. So what we're talking about is I'm on Medicaid, I have an allergy problem, I want to go to the store and get an antihistamine, which is going to help me lead a better life.
Yeah.
I can do that now and pay probably $1 copay. If we accept this governor's recommend of eliminating that possibility, me as a Medicaid patient would now have to go to the drugstore and spend $20, $30 for a prescription.
Okay, so, but a person on Medicaid can go to the store and buy that and only pay a copay of so much money?
Now, today.
Right, no, I get that.
Yes, $1.
Okay, I just wanted to,
Yep.
I'm trying to draw a distinction between over-the-counter and prescription.
Right, so none of this is prescription.
None of
They're
this.
all, these three drugs
over-the-counter.
are only over the counter.
Okay.
The $1 or so copay, not copay, sorry, it is $1 or so for the over-the-counter drug.
Right.
If this goes away, and we only looked at one example, Claritin, it would be about, 20, 25, I forgot what he said.
So this is all over the counter?
Yes.
That answers my question.
Yes.
Thank you.
Yep. All right, let's move on to dental.
Okay.
And we had the question about removing the dental cap.
Yes.
And
Who's going to join me for the slides?
Welcome, Ginger.
Of the technology.
Just give me a moment.
Yeah, take a moment.
I don't want to do
I'm
that.
happy to answer a question, try to answer a question.
Let's ask the question about, go ahead, Leslie, with your question, why we.
So I was looking at your narrative, dental rates, number 17,
Yes,
and that's great. Thank you.
thank you.
Dentists were very grateful. But I guess what I was wondering is, are you pegging those rates just the 23, or will it be pegged ongoing? As the Delta dental rates go up, your rates will automatically go up?
It's a good question. Thanks for asking. So right now, the rates that you're seeing there have used the 2023 Northeast Delta Dental Premier rate as a fee schedule. If Delta Dental decides that next year they want to increase rates by an additional, 5%, we do not have additional appropriations to do that. So we're only focused right now in perpetuity on 2023
I've done 23 rates.
or until something changes.
So it's like a lot of our Medicaid rates where we set it to a percentage of Medicare and Medicare may change, but you may not, as we saw with EMS.
Right, exactly. EMS, home health.
All of them.
So, may I?
Yeah.
So it sounds like what you're saying is there's really no sort of realistic way to do that, given the way the budget evolves. To
To build in,
build in that automatic increase, since you're pegging it to something like,
no, I mean, there's no automatic way to do that. We certainly try to, on a regular cadence, provide updates to rates. But that is all based on appropriations and availability of appropriations.
is that something that we could write in?
So I have hold on, only because I have a couple, I know where you're getting to, so I just have a couple questions.
Yeah.
How does DEVA determine what gets a rate study? Like, how does the rate study process work when you're looking at the Medicaid rates?
Well, we try to take a holistic look at them across, because it's not just DEVA. We have interactions and collaborations across the agencies. So sometimes it is an agency priority that this, for example, ACCS needs, the Assistive Community Care Services folks, that area needed a rate study. It's not really DEVA necessarily, but in conjunction with the Department of Aging, Disabilities, Aging and Independent Living.
Can I just ask you a question about that? Oh, but so that rate study was, and I may be wrong on this, was because of a legislative.
There's legislative needs, right? Agency needs is another area. And then department needs. So it really is, we try to take a holistic look across the board, which is easier said than done when we have so many segments, but we do try to do that. And if some of the challenge we have, I think, is the balance of, for example, EMS has not had a rate update in a number of years. And, I think there's a better way to look at these things.
Are there any categories of rates that are set either in statute, I guess it would have to be in statute, that, or in your policy that does get a review, like, let's pretend EMS gets a review every 3 years. Are there any rates in statute or in your policy
I'm
that?
not aware in statute.
Okay.
We do have our own internal list of, I think Alicia had come in, I think she had shared that on her slide, that they had a regular schedule. Do you remember that slide? We can share that slide again.
That'd be great.
Basically, the areas that we're responsible for that have regular schedules for reviews, right? Because we can't just do an update without appropriations. And then the areas that we don't have.
Oh, I do remember that slide. Yes, thank you. Okay.
But
We'll make sure everyone has
happy
that.
to share that again.
Okay. And yes, is there something we could do legislatively? Potentially. I mean, it's a big conversation.
yeah, may I ask another question? You just said something that you didn't think this system was maybe that good and maybe there's a better one. That might not have been your language, or I thought I heard that.
Better way to.
Better way, maybe.
Do the rate studies, yeah.
Could you comment? Are you prepared to comment on that? What might be a better way that we could think about?
Well, I think it's more, I was thinking more how we think
Yeah.
about reviewing rates. The challenge with rate studies is they take sometimes months and then sometimes years. And so managing that, I think, is the challenge, because some are more complicated than others. A lot of it depends on stakeholder engagement and the ability for folks to join in the discussion, because that's really where the best information comes from. So I am not the expert in that area, but I do think that in terms of process, we can create some more formal, like, we're going to do these priorities and start these priorities and then kind of fill in as time goes on in that pipeline sort of format. That's
You
how I
mentioned
look at
like
it.
EMS every 3 years or something.
Yeah, that was just
I mean, off the top of your head, but is there some kind of
Right.
model? Is that something you would do internally, or would you would need a nudge from outside, like a?
We don't need a nudge, we just need money.
That's our job.
But yeah, I'm half joking, but.
But we do know the dental rates that you're requesting now will be in the base going forward. They may not necessarily automatically increase if Medicare increases. Right, that would be another budget process. Okay, great. All right, dental rates.
For the record, I'm Ginger Irish from Department of Vermont Health Access.
Do you want to walk through? And I'll just comment?
Yeah, sure.
And do we have these slides?
Yes, they're on the website.
Yeah, happy to. So just to start off, I want to share that dental coverage is optional for Medicaid. States can determine whether to cover dental or not. It's not required federally. So in Vermont, dental coverage is comprehensive and mandatory for children and youth under the age of 21 with no cap. So there's no cap at all for that age group. That's part of the early periodic diagnostic screening and treatment. So all services for that age range under Medicaid are covered. Just to be clear, Medicare does not provide dental coverage other than very limited circumstances. Some people qualify for both Medicaid and Medicare. We sometimes refer to them as duals or dually eligible, and Medicaid does cover dental for those folks. In terms of the specific fiscal proposal on the table today, the governor's recommendation is to increase the Medicaid fee schedule to 75% of the 2023 Northeast Delta Dental fee schedule. So they're a private dental insurer. So that's really the benchmark that we're looking for. Our rates currently for Medicaid are about 50% of the 2022 schedule. So if you add a rate increase of 25% onto 50% of what we're paying now, we're increasing rates by 50%. That's the goal. The fee schedule hasn't been updated in several years. We've been hearing from dental providers that increasing the fee schedule will increase access for Medicaid members, which is part of our mission. So in terms of the cap specifically, there is a cap on some dental services for some populations. The cap is $1,000. It does not include preventive services. So if someone goes in for a preventive service, we will pay 75% of the new rate without a cap. So none of that counts toward the cap. In terms of prior authorization, our department just removed a lot of prior authorization for dental services, so access is easier for members and it's easier for providers to offer those services. So in terms of who's not subject to the cap, I talked about folks, children under 21 years of age. Pregnant individuals are not subject to the cap. And in terms of those individuals, there had been a 60-day postpartum period. Starting April 1st, that's extended to a year. So for a year after giving birth, postpartum people will not be subject to the $1,000 cap.
Can I ask a question?
Yeah.
What are preventive dental services? So is that like 2 cleanings a year or?
So there's not a requirement about the number of services, but things like a cleaning, x-rays, those types of treatments are preventive versus a filling or a crown. Those are the types of services. There is a specific list of which codes are preventive and which are not that our system counts.
All right, thank you.
So in terms of the question, how much has been allocated for Medicaid dental spending under the cap? That's actually not how we budget. We actually budget for total dental. So in terms of the anticipated projection of expenditures, state fiscal year 23, which is the year we're in now, is just over 26 million. And for 2024, which includes this proposed increase in rates to 75%, it's just over 39 million, almost 40 million. In terms of recent spending under the cap, we received some questions about that. So we have both the total and the average. So do folks here know about claims run out, what that term means? So when Medicaid gets a claim, so somebody goes in and sees a dentist and then they send us a bill, it takes a little while for them to code and send that bill to us and for us to then process it and send them payment. So there's always a lag between the day a Medicaid member gets a service and when we actually pay for that service. That's how that happens in commercial. That's just how health insurance works. So just to note, the 2022 figures don't include all of the services because there is a delay there. But the average spending for members who were subject to the cap, so not in those populations that are excluded, has risen from $250 to $328 over the past 4 years, still well below the $1,000. This does not include Medicaid members who did not receive any dental services. This is just people who got services, and they are well below that $1,000 cap on average.
So can I just paraphrase to understand, make sure I understand what you're saying? So the average spend for a Medicaid recipient who is subject to the cap, so it's not a child under 21, it's not a pregnant or postpartum person, was $328 in 2022. And that means that those people are not necessarily hitting the cap. So they're getting the care that they're requesting, hopefully, unless they can't find a dentist, and that they may not be hitting the cap. But this is an average, so probably some people are hitting the cap and some are not.
Yes, and just to follow on that, because I think the next slide is useful, this slide shows the percent who actually do meet the cap. So in 2019, it was nearly 11%. We did raise the cap from $510 to $1,000. And you can see that starting in 2022, when we did raise that cap, the number meeting the cap dropped again. Just want to note that COVID-19 certainly has affected utilization. We know there are workforce challenges and access issues, but these are the percentages of people who have Medicaid who are seeing the dentist and actually meeting the cap.
So let me just clarify. So the first column is the number of adults over age 21 who are subject to the cap. And then the next number is the number of those people who met the cap. Thank you.
Yeah, and who actually went to the dentist.
And who actually went to the dentist. Yes, obviously. Okay. Alyssa? I mean, Leslie?
I'm good with that too.
Sorry.
I think in your earlier slide, you said that dental coverage is an optional Medicaid benefit. So can you talk about how that works?
Well, I
Do you
think
buy in more or
states either choose to cover dental services or.
optional from our state point of view, not from the individual.
decided.
Got it. Thank you.
Yeah.
Mari, I think, has her hand up. Are you there somewhere?
Yeah, thank you. Do you have a methodology by which you can capture the numbers of people that may have, if they did indeed defer treatment because they would have hit the cap?
That's a great question. We'll talk about that on a later slide, but I'm happy to answer now.
We'll do it when we get to, is that okay, Mari? Do it when we get to the slide?
Yeah, whatever works.
Okay.
Okay, so moving along. So,
sorry, Art.
Yeah, just, this figure, Ginger, when you say it's people who went to the dentist, but did they go to the dentist for something other than the services that are free and don't fall under the cap? Or did they go for all things? Because that could really skew this a lot.
Yeah,
I think.
That's a great question. This is really just looking at the services that apply to the cap.
Okay.
We don't have a way of tracking the reason that they went in for the visit. We do know what they billed for. So if they had a visit and they got a cleaning and a filling the same day, we would be able to know that.
Okay, but this doesn't include the people that just went for a cleaning and that was it. Okay,
right.
Then this is a good figure. Okay.
So we did receive some questions from Representative Rebecco about what was the result of the increase in the dental cap. So did want to note that in the previous slide, it shows that we did see that the percentage of people who met the cap decreased in that time. Again, noting that in 21 and 22, a smaller percentage of Medicaid adults did use dental services because of the public health emergency. We don't know how utilization will change as we emerge. The federal public health emergency is ending in May, so things will continue to shift. The next slide, we are proposing in our housekeeping bill, H206, that Representative Goldman sponsored, eliminating the cap for certain vulnerable high-risk populations. These are folks with developmental disabilities and folks that are being serviced by the Community Mental Health and Rehabilitation Treatment Medicaid programs under the Global Commitment to Health waiver. So that basically says that those folks are not subject to the cap. In addition, adults in that 21 age plus category, if they are seeking treatment for pain, bleeding, and infection, the cap may be waived. So if it's serious emergency dental service, a cap will not apply. This isn't a proposal. I'll be testifying on Thursday about it. We don't know if this will pass or not, but our hope is that it will. And the populations specifically are defined by the departments that serve those populations. So Dale for the folks with developmental disabilities and DMH for the folks that have the mental health.
So can I just ask you a quick question? If I remember correctly, somewhere in our budget, is the budget associated with H206?
Yes.
Okay.
I can speak to that. There's some funds in other departments that we were able to move to DEVA to access a federal match, which will cover eliminating the cap in these specific instances.
Okay.
Is it for HCBS pops?
I don't believe so.
Is it for Daisy? What was your question?
HCBS, because I know at the bottom you have Dale and DMH and you reference CRT, which is an HCBS population under the waiver. So I wonder if it's all 5 HCBS.
It's just DS and CRT specifically.
Interesting.
My understanding. It's about, I think in our narrative, in our FY24 narrative, it was the dollar amount was around 118,000.
Yeah.
Number 14, number 14 on their narrative.
Sorry, Alyssa.
I'm just wondering, under your proposal, you have that it'll be covered after the cap. So if the emergency service happens before they have reached the cap, will it go towards the cap?
Yes. Yeah, so it basically means that the cap would not apply in those situations.
But then they would not be able to get services after that are not emergency because they've reached the cap on the emergency services. Possibly, theoretically.
Oh, I don't think that's true, right? Because they were removing the cap for those services.
You're removing the cap after the cap has been met. But if the expenses for the emergency services go towards the cap, then once they meet the cap, if they have non-emergency services afterwards, you will not cover those non-emergency services. I mean, it's sort of like meeting your deductible in a way.
Well, I think so for this population, we're removing the cap for all services.
For the DS and CRT,
For those populations.
we're removing the cap fully. The emergency services,
Yeah, I was talking about the emergency.
specifically for the 21 plus adult. I believe it's after they've met the cap, but that's something we can check on.
Yeah, but it shouldn't apply, I guess, is what I'm trying to say. It shouldn't be a barrier.
Folks with developmental disabilities, and they're served under a waiver program.
So DS stands for?
Developmental disabilities. And my apologies for using that.
We'll ask.
All right.
Don't worry, we'll ask.
Acronym, yeah.
Yeah, developmental disabilities.
Developmental services.
Topper?
Correct me if I'm wrong. If you're removing the cap, period, it shouldn't matter
Right, for those populations.
for those populations.
Yes, for those populations.
The cap won't be a factor.
So even if they go beyond the cap, it doesn't matter. The cap that existed before, you removed it, so everything gets taken care of for those people.
Right.
Daisy, did you have a question?
Yeah, and I'm just curious, looking at, the return on that investment of general funds for the federal match. Did you consider other populations, removing the cap for other populations? I mean, this is a very small population you're talking about. I know it is the most vulnerable populations.
It is, yeah.
But the return is significant.
Right, so I think we will get to other cap conversation.
Got it.
Later, but just to address this right now, this was an opportunity under the current waiver negotiation that we really needed to take advantage of. for lots of reasons. So that's what we did, and we're able to partner with the other two departments as well, so it serves everyone. But we can talk more about the variables related to removing a cap completely for other populations, and hopefully it'll come together a little better.
It doesn't serve everyone, I'm just push back on that.
For CRT and DS, I think it serves the members of
Those
the
two
populations.
populations.
So let's keep going with the presentation. Leslie, hold your question because I want to make sure we get this in.
Okay, so our proposal is to increase the cap to $1,500. Our fiscal estimate for increasing rates didn't tease out who met the cap and remove that when we proposed increasing rates to the 75% of Northeast Delta Dental. So there's not an additional appropriation that would be needed to increase the cap to $1,500 for that specific population of adults, 21 and older.
I wondered where that was.
Well, it took us a while to get there. For sure.
Hold on, we're going to finish the presentation. Hold on.
Oh, and I think I skipped this slide accidentally. So removing the cap altogether, it's really difficult for us to find out how to remove the cap. To Representative Cordes' question earlier, once a member meets the cap, we don't receive claims above the cap, so we have no way of knowing how much that would actually cost. We also anticipate that were the cap removed entirely, utilization may change. Some insurance, dental insurance has a cap. I think that's common in the dental insurance space. But removing the cap altogether could change provider behavior, it could change member behavior. So it's not possible to come up with an estimate for how much would it cost to remove the cap entirely for all of the Medicaid populations, which is why we propose increasing it to that $1,500. And then the last slide, we did receive some inquiries about tracking whether the rate increase is effective. There is some data available for that. I just want to note that we don't do this for all different types of providers. So I think there's a broad conversation potentially to be had about how do we track any changes fiscally to increases to access, and whether it makes sense to add this accountability for this specific provider group at this specific point in time. Something, and I don't know if you want to add to that.
No, I think you said it really well. We do this anyway. We're tracking this data anyway. So we have it available, but we do not want to create an equity issue across providers, sectors. If we're investing dollars, what's the accountability piece of that? Is not really a conversation we're having broadly, as Peter mentioned.
I'm sorry, I'm not sure really I understand that.
I think if there are requirements that, for example, let's use the dental proposal as an example. If there are requirements for the investment of the $13 million or $5.6 million in state funds, and they are required to increase access by X number of percent, and we need to make sure that we measure that. That's very different than how we measure other providers, whether it's primary care, home health.
Okay.
So it's an equity question, that's all.
But could you, in what you already do or have the capability to do, could you come back in a year and say, this increase in rates led to this many more people seeing a dentist?
Absolutely.
Okay, thank you. Okay, Leslie, and then Art, and then Alyssa.
I'm not sure this is what you want to talk about today and talk about it next time you come, but I was curious to know why you picked that particular population to remove the caps. What's unique about that group of people? And that may not be something you want to talk about now, but
Disabilities and community.
And the CRT, yeah. Mm-hmm. Why them?
Well, part of it was these are very vulnerable and perhaps lots of times difficult to treat individuals. And the other aspect of it is we had an opportunity in the waiver, and we needed to take advantage of that as well. So is there anything you'd want to add?
I would just add that because of, the mental health and disability needs of these populations, they often require different interventions like sedation, dentistry that are quite expensive. And so it's a way to give access to care for folks that really would not have access otherwise.
If I may, do they have greater dental problems initially than the regular population? And that's what made you think about it?
I don't know the answer to that, if they have greater needs. I would imagine they have more difficulty accessing care, so therefore could potentially lead to more complex needs.
Yeah, I'm just going upstream and saying, why'd you pick them? Thank you. Art?
Yes, I just want to make sure I understand this, and I think you said it, but I want to make sure. The $13.1 million request will cover the Medicaid rate change from 50 to 75. Do you think there's enough money in there to take the cap away, or to move the cap from 1,000 to 1,500?
Right.
Also,
Yes.
does the move to 75%, will that keep your dentist, the dentists that we have happy in terms of their reimbursement enough to, this might sound stupid, but I'm wondering if we moved it to 85% and left the cap at 1,000, whether that would keep your dentists happier, keep them working, and so we're not losing dentists.
It's a good question. I think that 75% is not the end. I
Okay.
think it's a huge step forward. I also think that if anybody offered dentists an 85% reimbursement rate, they would say
Okay,
yes.
I understand that. I don't understand the percentages of reimbursement. Why we're not reimbursing everybody 100%, I don't understand that. I don't get the dynamic of it. But I just want to make sure
Yeah.
that we're accomplishing our purpose and not enriching a dentist more than what he should be,
Right.
but yet not shorting him and having him throw up the hand and say, well, gee, I can't operate at a loss, so I'm leaving.
Right.
That's all I'm trying to get
I
at.
think we're still not covering costs at 75%. However, when we asked
Okay.
a number
All
of
right.
providers,
Yeah.
what do you think is going to
What would work.
move the needle
Yeah.
here and stop people from, first of all, stop them from leaving the program?
That's, yeah.
And also be willing to treat more Medicaid members, and it was 75% came out of that
Gotcha.
discussion, but I don't think it's the end. I think it's like every other provider rate, it's a long-term commitment.
Thank you.
Thanks.
To Art's point, my question really is, you've decided to tie it to 75% of 2023 Delta rates. We just heard testimony, well, it could have been a month ago or a day ago, on EMS. 75% in 2023 is going to be 75%. In 2024, it'll be 72%. In 2025, it'll be 70.
If Medicare keeps going up.
Or if,
I mean,
No.
Delta Denta keeps going up and we don't.
Yes, but typically, so why have you just not tied it to 75% of current year's Delta Dental? Because that seems like it would stabilize the dental program. I mean, are you gonna come back in 10 years and say, well, maybe we should raise the rates again?
I hope it's not 10 years.
I hope it's not either, but
Again, it all comes back to the appropriations needed to do that, and what the department strives for is to be able to account for some of that in our budget each year. And not have to ask for all those additional funds, but it's when you're talking about, I don't know how many sectors we have, it's at least 10, 12-ish. Would it make sense to do an incremental increase of a percentage for one provider sector and 0 for another provider sector? It just depends on.
I mean, I would say that it would be appropriate to have a percentage increase every single year for every single sector.
That would be ideal. I would love that.
That would be,
I would love the problem.
that would be ideal. And so we're not constantly having to put out fires.
I
It
don't,
feels like we're having to put out a fire with this dental.
yeah, it's a tough situation. I mean, and it is a governor's initiative, otherwise it wouldn't be in here.
Nolan?
I would just comment to say that there traditionally has been some hesitation on both, not just the administration, executive branch side, but also in like the appropriation side to have automatic increases in any rate. You know, there's been conversations of tying things automatically to Medicare. If you did it to all the rates, there's been a lot of pushback on the appropriations committees to having that as well. So the conversations in terms of automatic inflation rates to rate or inflation to rates automatically, that there's been resistance, not just from the executive branch, but also in the appropriations committee.
I guess I would just say that we have automatic increases every single year in administrative costs.
And they have to come in and ask for the appropriation of it. That's what the case, like for instance, caseloads go up. They have to come in and say, here, our caseloads have gone up. This is what it is.
No, I'm referring to state employees.
And again, they have to come in for their budget and say, here's our budgets. And they have to ask for it as part of the appropriation process.
Right, and isn't part of that we can't tie future legislations, right, beyond our 2 years here? What we could do is put intent language like we did in 167, which had unintended consequences, but suggest that the administration comes back with, you know, what we want to see, like what, you know, look at these two ways of doing this or something. So that is a discussion to have.
And another thing that I know some other committees have done in the past is ask the administration to report back what 1% in rate increases would be if they were to do it, even though they're not doing it, they give us the information to make that decision.
Madam Chair, if it's okay, I'd like to go back to another part of this budget.
Yes, let me just close out the dental. Anyone else have any questions on dental? Thank you for, stay right there, but thank you for all of the work on that. And then I just want to say Nolan and I discovered that the budget ask for the dental CRT group is not in our handy dandy budget sheet.
Great,
So-
'cause I thought I was going cuckoo.
Nolan is going to update that, yes.
Thank
I just wanted to note that that's actually a budget neutral proposal because we're moving funds from other departments over and then plussing them up through the global commitment waiver. So that may be why, because it is budget neutral to remove the cap for those specific populations.
So Nolan will look into that because it's, I mean, in your write-up, there is a $86,000 state ask.
And that's moving funds from DCF and DMH over to DIVA so that you can access the match.
Okay, so Nolan, can you just confirm all that and
Let's talk.
let us know? All right, where do you want to go?
I want to go to,
Is it Diva? It's still Diva, right?
E309, the Vermont Cost Sharing Reduction and Elimination. I think for my benefit, and I hope for the committee's benefit, can you help me understand this statement? This, the language is associated with B309, et cetera. For the elimination of Vermont cost sharing reductions, $500,000 approximately, which is a state-funded program to reduce out-of-pocket costs for eligible qualified health plan enrollees. That to me is the people. Am I wrong on that?
I'm sorry, I didn't hear.
That to me is the people.
That's the people. That's the people buying health insurance.
Okay. Now, how does reducing it help them with their out-of-pocket costs? Is
So,
that because the thing is eliminated, so they don't have to pay them anymore?
okay, so it's a good question. Let me just make sure I'm understanding it. So the Vermont Cost Share Reduction
Yeah,
Program
yeah,
helps people pay their insurance premiums.
Right.
It makes them pay less out of their own pocket. Because, I mean, when this I can't remember how long ago this was established. It was at least a decade. When it was established, it accomplished the goal of reducing costs people had to pay out of their own pocket. Over time, it has evolved so that there are lots more federal subsidies available and other kinds of subsidies available, so that this program doesn't serve the need that it used to serve. So again, another budget cut proposal we had to make was, is this a good use of state dollars? Probably not at this point in time. Could they be used differently?
So, I just want to remember, so Mike Fisher talked about this. This is that $500,000 that he suggested we not accept. And then Nolan?
I can explain it differently if the committee is looking. Please. Okay. Having been here when it was created. So the Affordable Care Act, when it passed, there were two subsidies in the Affordable Care Act. There is premium assistance, which helps people, helps reduce the premium. This is on the federal level.
Yeah.
And then there's cost sharing reduction, which helps reduce their out-of-pocket costs. What the state did was we said, we're going to go farther, and we're going to increase the premium assistance. So the premium assistance at the federal level is up to 400%, or it was initially at the time. And we did it up to 300%. So we just did an additional 1% on the premium assistance to buy down their premiums additionally. And then there's also cost sharing, where we took it a little bit farther than the Fed did on the cost sharing. So the premium assistance over here, we got Medicaid match on. The cost sharing reductions, the Fed said no. What is still existing is the federal cost sharing still exists, and the federal premium assistance still exists. But what's happened is, over the past several years, the federal government, through COVID and other stuff, have put more money into the premium assistance to help buy down people's premium assistance even more. And so what they're contending and saying is that because the federal government is helping people save money on the premium assistance side, they're saying they want to eliminate the state cost sharing, because they're saying they're getting that relief already from the federal side. Am I articulating that?
On the premium.
Is it the same people?
Yes.
Yeah, it's the same people. It's about 3,000 people.
That was going to be my question. How many people are we talking about?
Like 32 to 35.
3,000.
And what is the process at DEVA? What is the workload in order to eliminate this?
That's a great question as well. There are some technical changes that need to happen. It's a resource constraint. At the time that we proposed this, we didn't know when the end of the public health emergency and the redetermination of Medicaid eligibility would need to begin. So that is further complicating our situation right now.
Because really you need all hands on deck for the redetermination. So, I'm sorry.
If that's okay, I would just add that the redeterminations are federally required. There's no flexibility for us in the timeline. It's heavily regulated by Centers for Medicaid and Medicare Services.
So, reading between the lines, you have this big ask that you have to do by the federal government. Yet this, $500,000 is $500,000, but it's only
half a year.
Yeah, right. So there's going to be a big push to get that. And so we need to determine the priorities of where DEVA should be spending their time.
Okay, just so that I understand. I'm the person that's on Medicaid. The money that I have to pay for my premium is going to be reduced enough so that it would cover whatever I would gain on my out-of-pocket cost for histamine or whatever it's called. Is it a wash?
No, it's not a wash.
Is it, I'm the person, do I make out better or do I make out worse?
Depends.
And, huh?
Depends.
Jesus.
Yeah. Well, we wouldn't use Medicare as an example.
Okay, but Medicaid.
Let's use Blue Cross Blue Shield. It doesn't matter. You will have other choices. that probably would cost you less.
I'm
So it
sorry.
could work out in your favor if this was not available. It could, you could do okay, but there's no way to guarantee that. Like, there is a risk.
I would say that this is for plans people buy on the health exchange. So these are people who don't have Medicaid, they don't have employer-sponsored coverage, or if they do, it's not affordable. And they go and they put in information about their income, their household situation, their life situation, and then they get choices about how much to pay for their health insurance plan. And some of those plans have a really low premium. They don't cost a lot each month. But then if you go to the doctor, you pay a lot of your bill. And some plans, you pay a lot each month to get the plan. That's your premium. But when you go to the doctor, it doesn't cost you so much.
Okay, and your job, correct me if I'm wrong, and your job is after all that's done, after I do all that, deciding what plan I'm gonna be on and all that. And as we sit here today, I paid $5 out of my pocket. My question, because you talked about a lot of other money is coming in to reduce the premium. My question is, am I better off or not? Based on you eliminating that $500,000.
We don't know. I mean,
Why are we doing it then if we don't know? I thought it was to save money.
well, it is to save money. It is to trim our budget. And it is also to consider, is this the best use of state dollars now in the current landscape?
Okay, and I heard that loud and clear. What I'm feeling is, at least in the administration's point of view, it's a better way to go. Am I right on that?
I would say that,
Probably if you can't answer that, maybe.
well, I'm trying to,
Huh? Maybe, yeah.
sure.
I was just gonna say the federal government is giving people a lot more money for 3 years
Yes,
to pay less on premiums. So I think that's why the timing.
and that's what I heard.
But it's 3 years.
Yeah, it's 3
I think
years.
that's the issue.
And that's, I heard that.
Okay.
That's why I asked the question. I'm the person that's paying the bill out of my pocket. Am I better off under this proposal next year than I was this year?
You could be. Could be. We can't guarantee that.
All right,
I know.
I appreciate it. Thank you.
Alyssa and then Leslie.
So you're requesting to completely eliminate the cost sharing. So what happens in 3 years when the federal premium assistance goes down? We're not gonna, I'm assuming we're not gonna reinstitute that in 3 years, the cost sharing.
Maybe not the way it looks today. We might have other ways that we could think about how to establish something, but that program would be gone. Yes.
Leslie?
So you have a big job, the redetermination job, and it sounds like this is a confusing job. How do you prioritize what you're gonna do with these big jobs?
It's very difficult. We know we have a schedule. We have a very clear schedule with the Medicaid redetermination plan over the next 12 to 14 months. So we have folks ready to go. We have our communications ready to go. So we're really focused on that as our number one must-do priority. We have a lot of other technology projects in play right now. We have the technical changes that would need to happen for this Vermont Cost Share Reduction Program. We have technical changes that would need to happen and policy changes that would need to happen for the pharmacy cuts. We have rate, if there were something to move forward with rate proposals, we have those to implement. So there are lots and lots of priorities, and we really try to look at them on a weekly basis, at least, to determine what needs to be done now, how do we move things forward and make progress. So I don't know if that really answers your question, but the number one priority right now is we need to start redetermining folks And that needs to begin in a couple months.
And that is a requirement that has an end date as well from the
Right.
federal government.
Well, I have another question, but it's another topic. And it's also under AHS and not DIVA. So I'm not, but it has to do with redetermination.
Okay.
So it's the very bottom of the page, matching funds for one-time caseload pressures due to suspension of Medicaid redeterminations, $10 million. Is it okay to ask about that?
Well, and I also think Nolan can answer that, but
Okay, because I just want to understand that.
so let's come back to that. And Nolan can answer that for us when we go through. So anything else for,
One last question. I just wondered, DIVA's entire budget, what percentage is it an increase over last year's budget? Just the whole budget as a whole?
It's not an increase.
There's no increase?
In terms of caseload and utilization or the whole
The
budget?
whole budget?
I'll have to look at that. I thought we promised you an answer to that already, did we? I'll get back to you on that, because I think, Patrick.
I think it was asked before. I don't know if we got an answer.
No.
Increase in administration of 20.6 million gross and an increase in program of 64.2 gross.
But what's the percentage over last year?
80 million more?
We'll get back to you.
Okay, thank you.
Thank you.
If it's not in the budget book already, we'll get back to you with percentages.
Great. Thank you. Oh, yes, I'm sorry, yes.
Thank you. How would I get to them? One question, regarding in the A100s, there was a question about, limited service positions. 35 of them are reclassified to permanent status, which seems significant. Can you talk a little bit about why you would be reclassifying so many positions?
Sure.
And what that entails in terms of, salary increases or anything like that?
Yeah, I'm happy to. Thanks for the question. So Eva, let's see, it was last year, the department had a total of 133 limited service positions across the entirety of the department. And we were successful in converting 95 of those to permanent status. The primary reason for that is these were initially, more than a decade ago, they were initially established as grant-funded positions that had an end date. And when the grants expired, the decision was made at that time to build the staffing costs, all the benefits, the staffing into the base budget. And that was more than a decade ago. So in most cases, the funding ran out, they're part of our base budget, there is no fiscal impact at all. Most of these folks actually have the RIF rights, I can't ever remember the acronym. Thank you. And so they would find another place in state government anyway if they chose to leave. So these 35 are the last bucket of folks that are limited service at DIVA that were requesting to become permanent. Many of them, as you may notice, are in the payment reform team, the fraud, waste, and abuse team, the things that we really need folks to stick around for, and this helps with retention. We saw, as an example of a benefit that unintended at the time was we would try to recruit for limited service positions at an expiration date. There was, the eligibility group had a position posted, they received 17 applicants. When we converted those same positions, 2 or 3 of them were posted after they were July 1st, became permanent. We had 117 applicants. I think people expect to be working for the state for a long time. And if they see something that's limited service, they tend to not apply sometimes. So that's why we're requesting it. It's really something I think that is important for retention, and because we don't have new positions that we could request, this was an opportunity that I wanted to work on.
So I noticed as a follow-up, a lot of them were in healthcare reform and there were several in policy. Does any of that have to do with the change in leadership of your healthcare reform office? And is there any change in where that office sits?
No change in where the office sits. And we had requested these positions prior to any changes happening. Are you talking about Ina Backus leaving the
Yeah.
agency? So there was no reason, no correlation at any point in time related to Ina's position. But so Pat Jones is now named interim healthcare reform director. She has now taken that interim position at the central office. So her position would still be converted because technically she's still a DEVA employee.
Okay, I have a second question.
It's confusing.
Shifting gears. Around caseload and utilization, is the number reflected in this budget indicative of the fact that with the redetermination, you're expecting those to go down, yeah?
Yes, we do expect them to.
Okay.
Yep.
I know that was a question when we initially looked at it, or I don't know if we ever got a response, but just wanted to make sure because it was still pretty, I thought, relatively high.
We do. We don't truly know what utilization will do, because it could go up if folks go to the doctor more. But we think the caseload pieces will come down, but it will be a gradual decline, not a cliff, which is what we want, not to have people drop off.
Good. Thank you. So,
I'm not sure I understand what you just said. I'm sorry. Okay. You mean a cliff for your department, cliff for an individual?
Individual, so
So, yeah, what does that mean, a gradual decline for that individual?
for all individuals on Medicaid.
No, I understand that your plan is to go, through your population gradually over time.
Yep.
But it will be a cliff for the individual who, let's say, gets contacted tomorrow and says your redetermination is due, oops, you make too much money, you're not going to be covered by Medicaid anymore.
We're gonna help you hopefully.
We're gonna help you find another
It won't
plan.
be a cliff, that's the goal.
That's the idea, but you may not. Ideally.
Right,
Yeah.
we
We
hope
hope to.
that's
I
the
mean,
goal.
it helps with the additional subsidies right now.
It's made a huge
Yeah.
difference.
Health benefits, health exchange. Thank you both very, very much. We appreciate all your prompt responses you've given throughout this whole budget process for us. So thank you.
Thanks for having us.
Thank you.
All right, committee, do you want to take a 5-minute break or power through?
I
What are we
need
doing?
a minute, I need a minute. I'm gonna go for a
We're gonna
break.
go through this. I'm gonna tell you what we're not gonna worry about tomorrow. And then just have so I'm thinking we could be out of here at 4:15. So